Hey guys, Steve Krivjanik here, sitting with Dr. Roach.
Hey everybody.
We're going to try a new thing here from the EMS division called Protocol Minute. And this week we're going to be talking about a clinical case that I thought had some real relevance. And we were talking about, it's one of those things that we don't get to see a lot, and it's got some unique treatment.
Yes, it does. And just a segue onto what Lieutenant Krivjanik said, these monthly videos are so helpful. We take the findings from our CQI, the little nuggets we learn, and sort of share that with you just to help you learn the protocols better and to find those little confusing parts of the protocol. So I hope this helps.
So let's just take a look at our polymorphic ventricular tachycardia protocol, otherwise known as Torsades de points. I think one of the big things that I took away when we were doing some education on this last week is that for me, everyone knows that, Torsades gets treated with mag sulfate, but it's the patient that is no longer stable, that is the unstable patient, that you have to do a treatment that is like shocking, really, right? And that's
That's not a pun either. You have to shock them.
It's
shocking.
Exactly. And so when you tell someone, listen, I want you to put the pads on, don't delay, give them Tominate if you can, and weld them at 200 joules. Yeah. It's kind of shocking when they're sitting there looking at them alive. Right.
Yes. And we do cardio for people that are awake, same thing, but in this case, you're actually defibrillating them. It's the only time when you defibrillate an awake patient.
Right.
And has a pulse.
And that's crazy. And the reason behind that, doctors, to confirm, is because you can't capture an R wave.
That's correct. Yeah. Now the Zoll people claim that you can, and so theoretically, the Zoll, if you cardiovert it, it could deliver energy to a Torsades case. That's the only company I know gives that claim. But at the end of the day, they need electricity, as you stated.
Right.
When they're
the earlier the better.
When they're unstable, yeah.
All right, Doc. So I just wanted to touch on this real quick with you because it's the specific situation that I was talking about that we had last week with one of our crew members. It was really an interesting call that started in Torsades de point, one in a cardiac arrest, and it was identified as wide complex tachycardia. And actually, they did such a good job with the treatment through the cardiac arrest, they were able to obtain ROSC. Which was great. However, after the patient regained ROSC, it wasn't identified that the patient was in really wide complex tachycardia. It was identified that they were definitely in VTAC, but not really wide. And so we had an education session with them. Could you just touch on what the differences are there, and really how important the treatment methodology is there?
It's a tough situation because, like, even when you said that they were in VTAC, and because we use this nomenclature to indicate a wide complex tachycardia,
right?
And that's the reason why we developed these protocols and nomenclature. So a wide complex tachycardia, when it's VTAC, those are going to be rates certainly above 120, 130, more in the 160, 170 range. It's a tachycardic, fast heartbeat, right, with a QRS interval between 0.12 and 0.2.
Right.
So that's indicative of ventricular tachycardia. But a wide complex that's fast like that doesn't necessarily means that it's ventricular. It could be a left bundle branch block with aberrancy, it could be SVT with an aberrancy like a left bundle branch block. So these are hard things to differentiate. When we create this protocol on the really wide complex, it's saying, okay, when they're really wide, meaning greater than 0.20, and the rate is lower on the low side, like down in the 120s, that most likely, that wide complex is probably not of ventricular origin. That's probably something caused by a electrolyte abnormality, hyperkalemia.
Right.
So that's why we separate it, because if you give amiodarone, which actually does extend the QRS complex, it'll cause harm. It's an antidysrhythmic, and they don't have a dysrhythmia. They don't have a beat originating from the ventricle, which is where the amiodarone comes in handy. This is a situation where this is just a wide complex rhythm, and this differentiating to try to keep it simple is based on these little simple criteria. Rates lower in the 120 range with a QRS is greater than 0.20. You have to consider the idea that hyperkalemia is causing this, and a 1 gram of calcium is going to stabilize the myocardium, and it's going to allow the rhythm to narrow. The QRS complex will narrow in front of your eyes as you're watching the rhythm strip, and you'll be confirmed that you did in fact do the right thing and treated hyperkalemia and not given amiodarone for that, because obviously, as you stated, that would be harmful.
Yeah. So like when I was reviewing it, it was really interesting to me. When I went back and obviously reviewed the protocol with the crew, and the big takeaway for me is without a discernible P wave. and it was under 120.
Yeah.
Right, that was the biggest thing, because otherwise it just looked like VTAC. It just looked like VTAC all day long.
Yeah.
And I talk to them, and I'm going to steal some of the words that you always say. I talk to them about style points and and treatment, and the calcium chloride being absolutely critical to stop the myocardium from that happening, and the sodium bicarb. Hey, listen, if you got time, hey, listen, high five each other on the way in. They did everything.
Yeah, as we say, there's nothing wrong with style points, but the style points are not the critical action to save the life, like in the minutes. They're helpful in terms of keeping the potassium level down, shifting the potassium intracellular. That's all great, but calcium, as I stated, it will literally in front of your eyes narrow the QRS complex and fix this situation.
All right, so here we're just talking about Y complex tachycardia, and we're talking about in the adult patient and a stable Y complex tachycardia in the treatment. Obviously, Dr. Roach, it's the amiodarone infusion, right? 150 milligrams in a 50 over 10 minutes, and you can repeat one time. The big thing that we hadn't really talked about was when we rolled this protocol out was what happens if amiodarone's on back order. We wanted to add some secondary options in there, and what we put in there was we decided to put in there was lidocaine, 100 milligrams IV push. Is there anything special considerations we need to worry about with that, or we're not doing a lidocaine drip infusion anymore? We're just giving the lidocaine push.
Yep, the 100 milligram push, and I'll tell you, I've had some really good success with lidocaine, and I kind of prefer it over amiodarone in a lot of cases. But definitely, if you give amiodarone and you're not getting the effect, you can also add lidocaine.
Okay.
Even if and I'm happy to take the call real time if needed.
Awesome. Yeah, that's something that's really awesome about your availability to be able to call from these special considerations. Like we're talking about the special considerations after cardioversion. Like we had a patient like 3 weeks ago that I went to, and that person was getting welded by their implantable defibrillator. Yeah. And you sit there and they're like, stop this, stop, and it's like getting that amiodarone on board as quick as possible. And if it doesn't work, then hey, listen, let's get some lidocaine on board. Just making sure that we don't delay the cardioversion if they're unstable, but this person wasn't.
Yeah.
But we just want to make sure that we're getting that on board. Can you talk to why we have etomidate in our protocol for sedation versus Versed?
I like etomidate because it's more hemodynamically stable. That's why etomidate is the drug of choice for trauma and for RSI, because it's stable and it doesn't drop your blood pressure. So we already have a patient who's maybe unstable. That's why now you're going to give them a medicine that further drops their blood pressure. It's going to put
that makes sense.
We're going to make it worse potentially, even though we're trying to make it better by cardioverting. So the etomidate, it gives you it's a little bit sense of safety in my mind. For us, so that we don't cause more hypotension.
Right, and I mean it's not like we can't get it on quick. We can give it IO, that'd be pretty quick. Yeah. Okay.
Same as any other medicine, IO, IV. Yep.
Okay. Guys, thanks for your attention for this week's or this month's protocol minute. I hope you gained some information that was pretty valuable. Sure was valuable to me when we were reviewing it, and I appreciate Dr. Roach for being here and taking the time out of his day to make sure that this gets done.
I appreciate everything Lieutenant Krivjanik does and the whole team up here at EMS. This is incredible. What's happening right now for our agency is really exciting with CQY, whole blood, all of our protocols. This action, so thank you for what you do, and this has been great.
Happy EMS week.
Hey, send us some feedback, and if you have any points of interest or concerns, questions, send us some feedback so we can address it in the forthcoming videos.
Yeah, we would love that. Thanks, guys.